Hello, everyone. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. Thank you for joining us for the second in our series on preventing and managing COVID-19 in the workplace. This session is being recorded and will be available for distribution within 24 hours. You are on mute. We have a lot of participants today, so we're very happy you could join us. During the session, please submit your questions using the chat function on the Zoom application. Dr. Harris will answer your questions as time permits, and we'll summarize all the responses in a document similar to what we did last week. Any questions we receive after we run out of time, we'll be responding to those in writing in the summary. I'd like to reintroduce Dr. Harris for those of you who weren't able to join us last week. Dr. Harris is an MD, MBA, MPH. He's board certified in occupational medicine. He's WorkCare's Vice President for On-Site Clinical Services and an Associate Medical Director. Dr. Harris is serving as our lead clinician for the COVID-19 response. So as you can imagine, he's a pretty busy guy. I don't think he ever has time to sleep. But we really appreciate his time today. He's been following developments, and he can help us keep up to speed with all the responses that we have for protecting employee health. Now I'll turn it over to Dr. Harris. Thanks again for joining us.
Hey, this is Dr. Harris. Pleasure to once again meet here and talk with everyone. We'll be pretty quick with this presentation in that I want to make sure we get through all the material and be able to take questions. So I know we ran a little bit over time last time, and so we'll try to keep it to the time here today. So without further ado, we'll get back into the structure that we saw last week. If you're new and joining us, thank you for joining. And the goal of this presentation, again, is not to reverberate some of the things you found or may hear in the media necessarily. We all know there's enough sound bites for those type of data inputs. This is specifically to drill down into several topics: the clinical update on COVID-2, SARS-CoV-2, the pathology, microbiology, we're going to update on that. Then we'll get into the epidemiology, how it's spreading, in particular US focused. We'll look at the global picture a little bit, focus in on prevention and strategies that we can then take forward in the workforce that we're deploying with our customers and with our large employers nationwide. So let's drill down into the clinical update here. So I left some of the material from last week so that we can make sure everyone's on the same page with regard to the manifestations typically of SARS-CoV-2. COVID-19. Cough by far and away is the number one, or excuse me, fever and cough are the number 1 and 2 presentations, followed by chest pain, tightness, shortness of breath. And then what's new and still being looked at is GI symptoms. One study has shown, and this study was a pretty substantial study out of China, looked at over 55,000 individuals that presented with COVID-19, and they had about a 3.5% presentation of GI symptoms, in particular diarrhea. But a study out of China more recently has looked at a vastly smaller subset, a little over 200 people that presented, and up to 18.6% of those individuals presented with either diarrhea, vomiting, or abdominal pain. And that is a presentation that does come in concert in this study with other symptoms. Only about 9% presented with symptoms that were only related to GI symptoms. So again, it's just to note that we still need to look at how people present, and the classic presentation may not be the full picture. Incubation period hasn't changed, 2 to 14 days, and the average time of onset is 5 days. All right, from someone contracting COVID-19 contracting SARS-CoV-2 to developing COVID-19 symptoms, up to 5 days is that data. And then in terms of increased risk, those who are at increased risk, still far and away, the data is saying the elderly and those with pre-existing conditions. In particular, with regard to pre-existing conditions, drilling down into what conditions matter in terms of impact of this disease on individuals, cardiovascular disease is number one. 10.5% of people that contracted COVID-19 in one study, and looking at a couple of studies actually, did succumb to the disease, right? And so number two is diabetes, followed by pre-existing respiratory disease. Hypertension is amongst the list. There was some question of that previously, and diagnosis of cancer previously is also put you at increased risk for mortality or dying from COVID-19.
Dr. Harris, it's Karen. Before you go on, there's a question related to that, the symptoms that I thought maybe you could just address now, which is the discussion that's been going on in the popular media about loss of sense of smell and taste as new symptoms.
So so that's been going around, that loss of sense of smell and taste, in particular to the younger population, is what's been suggested. I have not seen any studies though that have looked at that specifically and correlated that to COVID-19. Perhaps that would be a good presentation to make if there is a correlation on our next webinar for sure in a week's time.
Okay, thank you. Sorry to interrupt. No
worries at all. So if we look at exposure risk in the U.S., one of the definitions that still is critical is the definition of sustained community widespread transmission, okay? And that definition is met by denotation with the CDC. The locations you can see here that have that designation: New York, California, Washington, Illinois, Georgia, and Massachusetts. Now, this is a self-reported designation by those geographics, local and state health departments. But what that means is that the community spread, it has elevated to the point where it is now considered sustained. And if you live in one of these geographics, you would have potentially higher risk in the general population versus living in another state that doesn't have this particular level of disease yet. But by far and away, we can see New York is number one. They have been on a course of doubling for the last couple of days the number of confirmed cases. And we'll get more into looking at those statistics shortly here. So in terms of the pathology and microbiology of SARS, again, just to make sure everyone who may be joining us for the first time is on the same page, the origin is in China, originated out of bats, and has a similar profile genetically to SARS back in 2003. Exploits a similar cellular pathway. Again, vaccine trials are still ongoing, and that is expected to continue to ongo with no particular vaccine to come to market, most likely within the next 6 months. But there are efforts to look at, and several universities are studying plasma from China of victims of those who've contracted COVID-19, and they are trying to accelerate the timeline for bringing a vaccine to fruition with that help from China. But the big understanding now I want you to take away is that there is 2 strains of SARS-CoV-2. Now, can the general population expect a difference in how these present? Perhaps. And what early China data showed is that the L strain actually was more prevalent and more aggressive. As they put into place their social distancing practices and they saw their rates decline, they saw more of the S strain in the general public, which is less aggressive, but still substantial in terms of total burden. S strain is actually denoted to be an older version of this particular SARS-CoV-2, but we yet to know the relevance from a presentation standpoint of these particular 2 strains other than its virility or aggressiveness. When we get into the epidemiology now, looking at a high level globally, what's happening around the world, we want to focus in on the population per million that have confirmed cases. Okay, and so the color denotation you see here darker blue, higher on the scale in regards to per capita, the number of confirmed cases. And if you look at the US, obviously we're on the upper part of the scale compared to China, and also compared to some of the obviously South American and Canadian regions. One of the things we have to pay attention to is the number of new cases, again, confirmed on a daily basis, and looking at that again at individual per million in the particular region. And so it's important to pay attention to this metric because this denotes how the actions of protectionism, meaning the social distancing and preventative methods, are working in terms of looking at, if you remember from last week, we talked about the S-curve of growth from a viral pandemic, and looking at this metric allows us to see, are we getting closer to the flattening of that exponential curve? And I'll point that out in particular as we go along here. But if you compare China to the US, and this scale is shifted towards purple and darker purple, darker purple is experiencing more confirmed cases on a daily basis in that region than those that are the lighter colored blues and pale colors here. And so we're experiencing the beginning still of our expansion in the US, whereas China is, as everyone may know, has tailed off. So quickly, let's compare where we were last week on this call on the 18th. US picture of the number of cases as well as relative size of the circles denoting the burden in that particular population. At that point, the total cases was 7,600 roughly, and total deaths 117. If we fast forward to today, the number of cases now is 54,400, and the number of deaths 737. Right, and if you look at the maps and compare, there's more scattered disease throughout each state than there was previously 1 week ago. And so again, this looks at the overall picture of where are we on the epidemiologic curve with regard to impact of this disease. We're going to do the same thing now looking at that S-curve. Again, I spoke to China tailing off in terms of their number of total confirmed cases. And the mid part of that S-curve there, again, is letting us take a window into how they, at what point in time they started to flatten the curve for increased cases, all right? And that's what we're looking for in the US. So if we now fast forward to this week in comparison, the total number of cases, we're catching up to China, right? And if you look at the global number of cases, again, last week it was over 160,000, closer to 200,000. This week we've doubled that globally, over 400,000 cases, right? And unfortunately, that's what we would anticipate seeing for a pandemic, and that's why we're taking these extreme measures that you continue to see across the country. If we drill down into then total confirmed cases, with the other countries now superimposed, we're seeing that Italy is again approaching China in terms of total number of cases. And what is alarming, however, as I spoke with a physician that leads a large university hospital in Italy last week, Italy, although they're catching up to total number of cases, is experiencing significant mortality with the number of cases versus that of China. So last week, total number of deaths, looking at the world pattern, China's pattern, which mirrored each other, and the United States still down at the bottom of the order. Fast forward to today, 1 week later, Italy last week surpassed China in terms of total deaths from COVID-19. Iran is catching up, and obviously with the US, we're trying our best not to catch up to the total number of deaths here. One of the things that we want to drill in on is the case fatality rate, and this is important in regards to that country's ability to respond to the burden and to help support clinically those who are affected. You've heard in the news, most likely, Italy has been struggling with the number of people that need respirators in the hospital, and even the physician I spoke with last week said they're converting the entire hospital to a COVID-19 hospital in one of their largest provinces in Italy that suffering the highest burden. And so certainly at this point, compared to China, Italy is experiencing greater mortality from COVID-19, and it is telling from the response standpoint in terms of why. So when we talk about prevention now, we want to drill in to make sure that we're doing everything we can to help prevent COVID-19. We're going to repeat this because it's valuable, right? Preventative strategy starts with good hand hygiene, cough etiquette, and social distancing. Those are the top three, right? But now we're looking at other strategies that are important to try to help in regards to doing prevention in the workplace, and we'll speak to a little bit more about IR thermography, and then also a concept of daily monitoring for the workforce. If we look at testing as well, I want to mention that briefly. All 50 states and provinces are testing at this point. And so the testing that we're talking about is using a kit and a swab of an individual that is suspected with COVID-19. And that kit is sent off to the laboratory, analyzed using a method called PCR. And that is what is producing the results that we're seeing nationwide in terms of approved tests for COVID-19. And these are FDA, CDC approved tests. But when we talk about screening and testing, right, there are limitations. So let's zero in on the infrared thermography. The infrared thermography, and depending on the device you purchase for your organization, and we know there's a number of organizations doing this now, large employers doing this, it can have false negatives. And one of those issues is related to the mode of detection of that IR thermometer. It can be up to plus or minus 1 to 4 degrees of Fahrenheit. So if you're looking at a normal body temperature, 98.6, and we're looking at trying to understand who may have a fever of 2 degrees higher than that, then we're well within the margin of error of many of the devices that are on the market, right? So we got to be cognizant to the fact that we still may be not capturing individuals with fever. Normal skin temperature, 92.3 to 98 degrees. So there is some deviation in terms of user making sure they're using the device properly with regard to where they're pointing the scanner in the particular body parts. But we believe that there is need for additional scanning, monitoring or screenings, and we'll talk about those strategies in a second. If we look at laboratory testing, however, we're still seeing, and this is data out of Italy, we're still seeing significant false negative rates. What the false negative specifically being, I am suspected of having COVID-19, I go get tested, and that test comes back negative. 30% of the time, that's the case, which is what Italy is experiencing. I have not seen any data out of the U.S. in terms of any studies that look at the false negative rate for the kits in the U.S., but they are the same type of test, PCR test that they're using in Italy. Is the same technique that we're using in the U.S. Second pass at a test, meaning that I take one COVID test and 24 to 48 hours later, I retest, that false negative rate drops to 9%. If I take a third test, that false negative rate drops to 3%. And so right now, the CDC recommendation in terms of particularly healthcare workers that experience symptoms consistent with COVID-19, there's two pathways to clear that healthcare worker to return to work. One of those pathways is a double negative test, meaning that that individual, if they've been confirmed to have COVID-19 via laboratory testing, then they need 2 negative laboratory tests to clear them for re-entry into the workforce. Again, these recommendations are from the CDC, and they're specific to healthcare workers, but I'm mentioning it because a number of our employers are looking to figure out a return to work strategy. And this certainly is amongst the criteria that we have implemented and we are recommending in regards to how we get workers back successfully at the lowest risk for any untoward outcomes. The other pathway is more of a clinical determination, meaning a clinician is not necessarily involved in the process. However, that individual follows a clinical pathway, and specifically CDC points out 7 days after onset of symptoms, as well as 72 hours after the symptoms have passed, particularly a fever, without using any kind of medication like Tylenol or other antipyretics to help limit the fever. So there are criteria that can help clear an individual per CDC requirements, but again, it's a rolling process in regards to, an iterative process in regards to how we're successfully getting people back to work. And we can share more of our experience after this call with questions and answers. So why are we doing all the screening? Again, why are we taking extreme measures to try to do social distancing? It's to prevent this curve, right? And this curve is showing in the yellow what happens, what happens in a pandemic if there's no measures to limit community spread, right? You get a very fast uptake of spread on the daily number of cases. If you start to institute measures like we have been, the goal is to bring the curve down to what's depicted here in the purple, right? But if we look at now what is actually being predicted for the US by institutions such as Princeton, Stanford in this case, they've done a model of looking specifically at are our measures going to work or are they not? And how long are we going to have to endure the extreme measures of shelter in place? And obviously this is germane to our workforce and our employers with the measures that are underway. So this particular study looks at hospitalizations, the number of hospitalizations as the metric for impacting the spread of COVID-19 in the US. And if we keep the strong distancing in place for 3 months, right, then this is the expected curve. And that line demarcates the growth of a steady growth of number of hospitalizations. And this is, again, using the practices that we have in place. If we expand that out to 5 months, the curve decreases more, right? So the total number that we get to in terms of hospitalizations decreases from 16,000 down to around 12,000 or so, right? And if we continue that for 10 months, that curve dramatically limits down to around 4,000 cases, right? And so this whole campaign is called Limit the Curve or Bend the Curve. And it gives us a window into how long we actually may be in the position that we are now with limiting social distancing and the shelter in place provisions that are right now in the US. For historical reference, with the Spanish flu, right, back in the early 1900s, they had and saw a similar epidemiologic curve, exponential growth. Some studies look at the number of deaths, retrospectively applying estimates up to 21 million people globally died from Spanish flu, right? And if we look at kind of what happened in history, they had like measures that we're doing now and trying to have extreme social distancing, shelter in place. But 4 to 5 weeks after they started to see a bend in the curve of transmission, those regulations were relaxed. And what happened was a recrudescence or a representation of the illness in the community. So the notion that we're going to be out of this in a couple weeks is probably not likely because of that phenomenon that was experienced back in the early 1900s. And it is what has been prognosticated, if you would, by epidemiologists, leading epidemiologists in the US. So finally, we'll get to, as we approach 22 minutes here, we'll get to strategies in the workforce and strategies that we've been pointing individuals to as well in terms of additional screening and checks, right? So that daily check or monitoring, or a momentary check, meaning that, hey, I'm feeling some symptoms. I want to make sure I can understand my risk. What should I do? Then the CDC has come out with a symptom checker, a self-checker. And once you agree to the terms, it's free to use. You can walk through even down to where you live geographically and get a result of estimating your risk and having some recommendations. Likewise, organizations like Blue Cross Blue Shield has developed an app that allows you to, one, take for free the screening evaluation, but then flow right into, if they are a carrier of yours, flow right into a telemedicine encounter. And have a clinician evaluate, hey, what are the next steps that we need to do to help you if you are at risk for COVID-19. WorkCare also has published a web app and questions that also help drive to a point individuals that may or may not be at risk. And we all may be familiar as well with what Google is doing in California. Also, again, screening, particularly in those areas that have drive-through testing, trying to get the right people, the right care at the right time. So there are a number of resources that we can share with you to help with this level of screening, secondary pre-screen and then secondary screening as well. When we talk about the daily screening and the home monitoring, we've in particular deployed a solution that looks at a daily screen in the form of a web app here. And you quickly take a daily survey. It's based on a concept of, it's called ecological momentary assessment, where you're able to capture in the moment what someone is experiencing, whether that's right before work or at midday. And data shows from psychology back in the mid-70s up till now that you can get far more accurate results when you do a daily screening for those who may be experiencing various symptoms. And you get a quick result of clear for work or remain at home. So this is a strategy that we've deployed, and we believe that we've encountered that a lot of our, a growing number of our employers are doing some daily screening of some type, but it's difficult to do at scale. And so providing tools to help is something that is afoot amongst other providers as well. When we talk about mental health, and this is kind of a teaser as we're winding down here this is kind of a teaser for our next presentation next week. Mental health is going to be what we believe a growing need in the workplace with the current state of affairs. If you look at the general population, 13 or older in the US, 3.7% of individuals will experience PTSD of some sort, right? 5.7% at any point in their life in a 12-month period. So, excuse me, 3.7 in a 12-month period and 5.7 at any point in their life. And if you look at the impact of work on the presence of PTSD, the workers who experience an injury per se, 44% of them, up to 44%, can develop PTSD. So now imagine the impact that our current state is having on our workforce in terms of disruption of normal life, disruption in the workplace, and disruption at home. And the experience uptick that we're going to see in terms of the impact of mental health. And so we want to make sure that we're providing tools and techniques to help stay ahead of the curve that we're going to see most likely with those type of impacts from COVID-19 in the workplace. And so with that being said, I'll stop here. I'll start to take questions and we'll get down into any details that individuals may want to cover right now. Thank you.
Thank you, Dr. Harris. This is Karen again. We're going to start with a couple questions related to social distancing. One of them is about whether you could do social distancing in some states as opposed to other and still be safe. The question is, can you selectively do social distancing in the hotspot states like New York, California, and Washington, and let other states with fewer cases go back to quote unquote normal life?
Right. If I understand the question correctly, can you have a regional approach or a very local approach to social distancing that it still is adequate for controlling the spread of the disease? The answer is we don't know. And I haven't seen any data that points to a strategy other than the one we're using now, where we have to kind of holistically limit individuals from moving around, basically. Last week I showed a cartoon of pockets of communities, and if one infected individual moves from one pocket to another, eventually you still have doubling of the virus amongst the entire different communities. So it is important to limit social spread on a mass basis.
Okay, and a follow-up from someone in the environmental construction industry wants to know how you can practice social distancing when you have 8 to 10 guys in a van.
To be honest, the answer is you can't. And we are seeing that with our construction partners, where they're busting in 1,000 workers onto a site, and practicing just social distancing is just not there. And so that's why it's important to have alternative strategies where we're able to capture those who may be at risk, right? Like we talked about with the daily screening, so that they don't ever get onto the bus and potentially infect other individuals, not with just COVID-19, but with just a run-of-the-mill cold, right, or flu. So we want to make sure that we have other strategies in place, and that's why we're recommending as such.
Okay, and the same person also asks if they can take the employee's temperature during safety talks, or if they believe they are sick.
So I believe that, if they believe they're sick, our strategy and approach has always been, please, if you can remain at home, please remain at home, and notify your HR or supervisor. The approach of testing on site is one of before you enter into a environment with other workers, whether that's in a social distancing or close proximity, to do some type of screening, like with fever or self-reporting temperature, and those strategies limit someone from even entering into an environment where they can transmit if they should be happen to be infected. Doing so in a safety kind of setting, as long as if that's all, if that's the best setting for you for that particular business case, then some is better than none, if I could put it succinctly.
Okay. There's a couple questions related to the global picture and what happens in other countries. In China, the question is, didn't they start doing chest x-rays with a smaller false positive rate?
So say that one more time, I apologize.
Didn't China start doing chest x-rays with a smaller false positive rate?
Not that I'm aware of. I haven't particularly, I'm not saying they haven't, I just haven't seen that data with regard to using x-ray as a screening tool for, in this case, it would be pneumonia. Granted, it's used clinically, but I haven't seen any studies that have shown specific numbers attached to the efficacy or sensitivity and specificity to coronavirus.
And what is it they did differently in South Korea than they've done in other countries to lower their curve?
They've done the measures we're doing now, social distancing. They've, instituted, in some cases, PPE where appropriate for the healthcare workers and those who are having front-facing general population. And then they've limited travel. You saw the travel bans that China took extreme measures to, as well as South Korea in particular. I spoke with a South Korean physician last week as well, and his experience largely played off of their experience from 2003 with the first SARS, and they had a huge number of infected individuals during that epidemic, and they learned a lot, and they put into place measures, had emergency processes and we're well prepared for this go around of SARS-CoV-2.
Okay, we're getting so many questions, we're not going to be able to cover them all, but let's just try to do a couple more before we conclude. If you have, let's see, what's your recommendation for mitigation if we're having workers within 6 feet for a majority of the day? Do you recommend N95 masks? If we run out of those, what do you have for a secondary recommendation or alternative?
And the question is speaking to recommendations for healthcare workers or for general population workers that are working in proximity to other coworkers?
Does not specify.
Okay, gotcha. Got it. So yeah, for healthcare workers, what we're recommending is if you are doing some type of patient care and you're within 6 feet of patient care that are presenting with symptoms, then we recommend PPE N95. If you don't have a appropriate gown, it's certainly a Tyvek a gown or donning that appropriate PPE is required. If you are working outside of that 6 feet zone, particularly for greater than 10 minutes as well, you're not in that zone for greater than 10 minutes, then the PPE is optional and not mandatory is what our recommendation has been. If you're the general population, you're showing up to work with other individuals that obviously aren't segregated as being sick or ill, then in those cases, a PPE is not at this time required or necessarily recommended. Now, we know that individuals are wearing masks, surgical and N95s electively, and we don't frown upon that practice whatsoever. And to speak to N95s, I know there's been a shortage. There has been some news that N95s are being made now in the U.S. Manufactured at a rate of 35 million a month. So we're hopeful that the first batch of that production will go into effect soon. California, New York are the first designations of receiving those supplies, but soon all of us should have appropriate PPE when those situations are required.
Okay. And some clarification on the difference between the S strain and the L strain. Are there tests to determine the difference between the two and how they contribute to infection rates?
And I apologize on my end, the internet cut out a little bit here. Say that one more time.
Can you talk a little bit more about the difference between the S strain and the L strain and how they determine which one is potentially responsible for higher infection rates, and is there a test that can be used to evaluate that?
Yeah, so there's not too much known about the two different strains other than that they do have common origin, and it looks like the S strain preceded the presence of the L strain in the population, and again that the L strain is more aggressive that they've seen, and this is all data coming out of China, and the actual clinical presentation effect, no one has studied, to my knowledge, the actual effects, and this study in particular points towards the need to do those type of studies. And so based on the lack of knowledge around the impact clinically, testing for each strand at this point would not afford us any further insight into an individual's course in terms of recovery. There is data that is similar that doesn't speak towards the strands, but more so the presentation of that individual. I'm speaking to the GI, gastroenterology, the stomach and digestive tract effects that people are presenting with. Those individuals who were hospitalized that presented primarily with that as one of their symptoms actually presented later to the hospital and as well required a little longer treatment and support versus those individuals who didn't have GI symptoms. So the studies are forthcoming, but that particular study on the effects on as a result of the strands, I have not seen yet.
So there's a lot of questions about masks. And, you know, you see people out shopping, they're wearing masks. The CDC has advised against wearing masks unless you think you're contagious or you work in a high-risk setting. Could you offer some advice just for common use around your community, whether you should or shouldn't wear a mask?
Sure. At this point, it's completely elective. No one has looked at, I've not seen any data to show the impact of wearing a mask on your risk of contracting or not contracting SARS-CoV-2 and COVID-19. So at this point, the only recommendation is that it is elective and only required for those individuals that may be at higher risk of contracting COVID-19 as a result of their employment, i.e. Healthcare workers, etc.
Okay. Well, we have time for one more question, and I just want to reassure all of you, those who have submitted questions, that we'll be answering all of them and distributing the answers in writing. So all of your questions will be answered. In the interest of time, though, we have to conclude in the next couple minutes. The last couple questions we've gotten relate to mandatory medical exams and drug screening and what the current situation is with the status of getting testing that it needs to be done and has kind of been put on hold.
So the question is relating to what has been tested.
Well, here's an example. What is WorkCare suggesting for scheduled physicals? Should they be postponed? What do we do about expired physicals? Will there be a WorkCare statement we can provide to our clients that explains why a worker's physical or work status will be expired at this time?
Got it. And so
there's been a couple of other related questions, like what's happening in the clinics where we send people for physicals. You know, I think people are very concerned that if they postpone, then they'll be putting people at risk of exposure to other hazardous conditions,
Sure.
And they're not really sure what to do.
Got it. I understand the question now. So what we've seen in the clinical community is a now kind of generalized realization that routine tests may be increasing risk for transmission because of commingling of individuals unable to do social distancing in the clinical setting. As a result, there has been consideration by not just clinicians on the front line, but also organizations such as the FMCSA that governs DOT physicals, as well as ACOM, the American Association of Occupational Environmental Medicine, to request to the governmental agencies a delay of changing anyone's status that require annual testing as a result of not being able to get in and be tested. In fact, clinics are now saying we're postponing PFT certainly and any routine screening that is not essential, meaning that it's not needed for, let's say, a EMS worker or a first responder, right? So those are the situations that we're seeing play out in the clinics nationwide. In terms of official announcements that those screening delays will be forgiven or just parlayed for now, state by state, we're seeing that happen as well. State agencies come out and say, we're not going to cause expiration of your license as a result of not having routine testing by such and such date. But it is at this point, what I've seen is it's a state by state consideration, and it hasn't been a federal declaration from any one body as of yet. We are anticipating something from FMC. I'm anticipating something from FMCSA with DOT, but I have not seen that come forth yet. If anybody has, let me know. But I also follow routinely Natalie Hartenbaum, who's the lead physician with FMCSA, and haven't seen it come from her yet either.
Okay, thank you, everyone. I just wanted to conclude by mentioning that we're posting a blog today for those of you who may have surplus respiratory protection equipment that you would like to donate to healthcare professionals on the front lines. There's some instructions on 5 different options for donation, and that'll be on our website within the next hour or so. Thank you again for joining us. We'll be back on with the next in our series a week from today, 11 a.m. Pacific time. We'll look forward to joining us then. If you have questions you want to submit now, you can send them to alexis.lupo@workcare.com. And we'll be summarizing everything for you this afternoon and have it out by tomorrow. Thanks again. Thank you, Dr. Harris.
Thank you. It's been a pleasure.